Welcome to a deep dive into the fascinating world of veterinary neurology. Today, we're exploring a groundbreaking study on the use of a common sedative, butorphanol, as a potential indicator of intracranial disease in dogs. This research, conducted by Emma Sandsby and colleagues, investigates how dogs with intracranial space-occupying lesions, or indicators of intracranial hypertension, respond to butorphanol, compared with dogs with normal brain scans. The study's findings offer a non-invasive way for veterinary professionals to predict which dogs may be at risk for increased intracranial pressure, which can be critical when planning anesthesia. Introduction. The journey begins with understanding why this research is so important. Magnetic resonance imaging, or MRI, is a crucial tool for diagnosing brain issues in dogs. General anesthesia is necessary for MRI, but can be risky for dogs with increased pressure inside their skulls, a condition known as intracranial hypertension, or ICH. Intracranial hypertension is a result of a variety of conditions, including intracranial space-occupying lesions, also known as ISOLs. Intracranial hypertension is defined as a sustained, directly monitored intracranial pressure of 20 mm of mercury or greater in dogs. Direct monitoring of intracranial pressure is rarely performed in veterinary medicine due to its invasive nature and the skill and equipment required. Therefore, non-invasive mechanisms to determine the presence of increased intracranial pressure are beneficial. Indirect indicators of intracranial hypertension, such as specific types of herniation, compression of the third ventricle, and perilesional edema, can be found on an MRI. Additionally, dogs with intracranial hypertension have been found to have larger optic nerve sheath diameters and higher lesion-to-brain volume ratios. Anesthesia can negatively impact the brain by affecting cerebral autoregulation. The goal during anesthesia is to maintain blood flow and prevent further increases in intracranial pressure. Currently, there is no method to determine if a dog has a space-occupying lesion or intracranial hypertension prior to anesthesia. Opioids such as butorphanol are often used as a pre-anesthetic to make handling easier, calm the animal, and make the induction of anesthesia smoother. Butorphanol is an opioid that is authorized for use as a pre-anesthetic medication in dogs, and can be administered intravenously, intramuscularly, or subcutaneously. In healthy dogs, it produces mild sedation. However, it is thought that dogs with ISOLs and intracranial hypertension have more profound sedation with butorphanol administration. This study was designed to test if dogs with ISOLs, also called MRI-iSOLs, or indicators of intracranial hypertension, also known as MRI-ICH, have higher sedation scores and more rapid onset of recumbency after intravenous butorphanol administration. The researchers hypothesized that a dose of 0.2 mg per kilogram of butorphanol administered intravenously would result in significantly higher sedation scores and more rapid recumbency in dogs with MRI-iSOL and MRI-ICH. Study design. This study was a prospective observational study conducted at a veterinary referral hospital. The study included 53 dogs presenting for brain MRI between December 2022 and September 2023. Dogs that were not able to have an intravenous catheter placed without chemical restraint, or that had a contraindication to butorphanol, were excluded from the study. The study was approved by the institution's internal review committee, and informed owner consent was obtained. Upon arrival, the dogs were weighed and received a physical and neurological exam. An intravenous catheter was placed in the cephalic vein. The dogs were moved to a quiet room, with controlled light and sound levels, and remained on the floor with a veterinary anesthetist, or veterinary anesthesia resident, and a registered veterinary nurse. All personnel were blinded to the dog's clinical history. A modified sedation scale was used to assess the dogs before and after butorphanol administration. This sedation scale involved observation of the dog's posture, palpebral reflex, eye position, jaw and tongue relaxation, response to noise, and general appearance. A score between 0 and 4 was assigned for each category, resulting in a maximum possible sedation score of 18. The dogs were scored before butorphanol was administered, at 0 minutes or T0. After verifying the catheter's patency with saline, butorphanol was given intravenously at a dose of 0.2 mg per kilogram over 30 seconds, followed by additional saline. The time to onset of sedation, indicated by muscle relaxation and head drooping, and time to recumbency, was recorded. Sedation scores were assessed at 5 minutes, 10 minutes, and 15 minutes after butorphanol administration. Following the sedation assessment, the dogs underwent brain MRI. The MRI images were assessed by a board-certified veterinary neurologist for the presence of a space-occupying lesion and qualitative and quantitative indicators of intracranial hypertension. Dogs with 3 or more qualitative features, shown in Table 2, were defined as having MRI-ICH. These qualitative features included the presence of transdentorial, foramen magnum, or subfalcine herniation, caudal displacement of the lamina quadrigemina, third ventricular compression, perilesional edema, and falcine shift. The cross-sectional area of any lesion and the maximal brain area, measured at the level of the lateral geniculate nucleus of the thalamus, were measured. The optic nerve sheath diameter was also measured, and the optic nerve sheath diameter to body weight ratio was calculated. Results: out of the 53 dogs in the study, 19 had an ISOL, and 10 had indicators of intracranial hypertension on MRI. All dogs with MRI-ICH also had MRI-ISOL. Dogs with MRI-ICH were older than dogs without. There was no correlation between age and sedation scores at either T0 or T15. The median sedation score increased from 1 at T0 to 6 at T15. Dogs with MRI-ISOL and MRI-ICH had significantly higher median sedation scores than dogs without at T0 and T15. Figure 1 shows the sedation scores at baseline and then at 5, 10, and 15 minutes after intravenous injection of butorphanol. Figure 1A shows a box and whisker plot of the sedation scores of dogs with MRI-ISOL compared with dogs without MRI-ISOL. Figure 1B shows a box and whisker plot of the sedation scores of dogs with MRI-ICH compared with dogs without MRI-ICH. A greater proportion of dogs with MRI-ICH reached recumbency when compared to dogs without MRI-ICH. Additionally, dogs with MRI-ICH reached recumbency more quickly than dogs without. Table 1 displays the sedation scoring system used, which includes assessment of posture, palpebral reflex, eye position, jaw and tongue relaxation, response to noise, and general appearance. Table 2 lists the qualitative and quantitative features assessed on MRI for indicators of intracranial hypertension. Table 3 compares the optic nerve sheath diameter to body weight ratio and the cross-sectional lesion area to brain area ratio in dogs with and without MRI-ICH. No significant difference was found in the cross-sectional lesion area to brain area ratio or the optic nerve sheath diameter to body weight ratio between the two groups. Discussion. The study successfully demonstrated that dogs with MRI-ISOL and MRI-ICH have higher sedation scores following butorphanol administration than dogs without these conditions, supporting the researchers' hypothesis. While the difference in sedation scores at T0 was statistically significant, there was a greater clinical difference between groups at T15, which is easier to recognize. This clinical difference supports the use of butorphanol as a premedication to identify which dogs might have ISOLs or intracranial hypertension. These conditions can result from neoplasia, inflammation, infection, vascular disorders, injury, or fluid accumulation in the brain. The Monroe-Kelly doctrine states that the total volume of the brain, blood, and cerebrospinal fluid within the skull remains constant. Compensatory mechanisms help maintain constant intracranial pressure, but when these mechanisms are overwhelmed, small increases in volume can cause significant increases in pressure, leading to brain herniation and decreased cerebral perfusion. A significant portion of dogs with evidence of brain herniation on imaging do not have clinical signs that are attributable to herniation. The study results suggest that greater sedation, both before and after butorphanol, could indicate intracranial hypertension. However, it is also important to consider other factors, such as recent medications or seizures, which could cause sedation. Nonetheless, a higher sedation score at T15 after butorphanol is a good indication of MRI-ISOL or MRI-ICH and warrants alteration in the anesthetic management. This can include adequate preoxygenation, head elevation, and avoiding jugular compression, as well as other methods to prevent elevated central venous pressure. The anesthetic induction should be smooth and the depth of anesthesia should be adequate before tracheal intubation to prevent coughing, and mechanical ventilation should be used to maintain a low normal end-tidal carbon dioxide. Optic nerve sheath diameter has been a reliable indicator of intracranial hypertension in humans, but no significant difference was found in this study between dogs with MRI-ICH and those without, contrary to previous studies. While other studies have shown that dogs with MRI-ICH have higher T2-weighted lesion volume to brain volume ratios, this study did not find a difference in the cross-sectional lesion to brain area ratio. This may be due to the fact that lesion area was measured rather than volume. Further research is needed to determine if this method of assessment is reliable for use in dogs. Although the observers were limited to board-certified veterinary anesthetists or residents, there is potential for inter-observer variability. However, the sedation scale used in this study has demonstrated good reliability between observers. Limitations of the study include the inclusion of dogs on anti-seizure medications or preoperative osmotic therapy. These medications may have affected sedation scores at T0. Additionally, dogs that could not receive an intravenous catheter without sedation were excluded, which may have omitted some dogs with intracranial disease. However, the researchers believe this unlikely since all dogs with MRI-ICH in the study became sedated. Conclusions. In conclusion, when a dog is suspected of having intracranial disease, performing a sedation score before any medications are given is recommended. If the dog becomes recumbent, or has a sedation score of greater than 10-15 minutes after butorphanol administration, an anesthetic protocol for patients with increased intracranial pressure is recommended. This simple, non-invasive test can help veterinary professionals provide safer anesthesia for dogs at risk of increased intracranial pressure. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.